set up for you. And so let's start with a quick introduction. Like I said, this is Dr. Gregory Deirmengian. He is a board-certified orthopedic surgeon who specializes in primary and revision hip and knee replacements. He sees patients in our Marlton, New Jersey office, as well as our Washington Township office. And I will turn it over to him because I know he's got a little bit more of an intro for himself. So thank you, Dr. Deirmengian.
Thank you. Thank you, everybody, for coming on. Hopefully, this will be a useful talk, and then we can answer questions as well. So the topic that I chose to present today is rapid recovery after total hip and knee replacement. What makes a difference? And the reason that I picked this topic is the questions related to the recovery are probably the most common questions I get in the office. So I feel, from a patient standpoint, this is what seems to interest everybody the most for good reason. Often the most common questions that I get. So I try to cover them in here so that everybody can get as much out of this talk as possible. My own background, I am a native of the Philadelphia suburbs, born and raised in the area. I went to Princeton University for college. I went to a medical school afterwards where I stayed on to do my residency. So after those 8 years, I did an extra year of hip and knee replacement specific training at the Rothman Institute. I joined the practice right after my fellowship, and I just started my 16th year in practice this August. My practice involves evaluating hip and knee pain in patients who may benefit from joint replacements. I also evaluate patients with a problem hip or knee replacement that might benefit from a revision or a redo hip or knee replacement. My offices, like was mentioned, are in Washington Township and Marlton, both in New Jersey. And my offices, I operate at Jefferson Health, Washington Township in Sewell, also at Jefferson University Hospital main campus in Philadelphia, and at the Jefferson Cherry Hill Surgical Center, where I do outpatient hip and knee replacements for patients who are candidates for that. So the goals of total joint replacement are elimination of your joint pain, restoration of function. Patients can often get very debilitated from arthritis, and restoring that function and their quality of life is one of the goals. Avoiding complications with surgery obviously is critical to having a good outcome. And then achieving implant longevity, minimizing the risk of needing more surgery, hopefully within a patient's lifetime, if not for a long, long time, depending on their age when they get their joint replacement. Questions that are most often asked to me in the office, which has led to this being chosen as the topic for today's talk. They ask about minimally invasive surgery, about the size of their incision, whether or not we cut muscles or tendons when we're doing the surgery, whether it's a hip or a knee, whether or not robotics are used for surgery, and whether or not they can go home the same day. These are very common questions, all really related to the recovery. From a patient's perspective, what they experience is, or what they want to experience, is getting their surgery done where they don't have too much pain. They have a rapid recovery so they don't put a hold on their life, whether it's for work reasons or just to getting back to their family life and getting back to the regular activities. And then, obviously, for some patients, cosmetics are important. They want an incision that's not that visible and that looks nice. So, what is the definition of a rapid recovery, just so we can all be on the same page? In order to have a rapid recovery, we have to do everything we can to minimize postoperative pain. If you're having a lot of pain after surgery, that's going to stop you from recovering quickly. Some people define it as the time spent in the hospital. If they're in the hospital for 2 weeks, like patients used to be decades ago, that's much different than somebody who's going home the same day. Whether or not a patient goes home or to a rehab facility, we really are not sending many of our patients to rehab facilities anymore, but that certainly has play into what a rapid recovery is. The time to independent ambulation, in other words, for how long am I going to need a walker or a cane, the quicker you can get back to independent ambulation without an assisted device, walking without a cane or a walker, that can be defined as a rapid recovery. Time to return to work for some reason. Obviously, they need to make a living, they need to get back to their job, and how quickly it's going to take them to get back to that job can be what's most important in terms of rapid recovery. And then time to your optimal outcome, the full painless and functional recovery. So these are all different aspects of a rapid recovery. So what influences rapid recovery as it relates to surgery? Well, what's important to understand, and really is the theme of this whole talk, is that not one single thing does not influence rapid recovery. It's a bunch of different things that act in combination together and actually feed on each other to improve the recovery. So it's what we call the multimodal approach. In other words, we pulled different things from different areas of the recovery, which we'll cover, and them acting together is what leads to that rapid recovery. And we can break these factors up into pre-surgical factors, surgical factors, and postoperative factors. And again, all of these factors act together, and the result is hopefully a rapid recovery. So, what are those preoperative factors? Well, first of all, there's patient factors. What is their body mass index or their combination of their height and weight? What is their age? What is their preoperative functional status? Were they using a walker, a cane, or a wheelchair beforehand? What are their medical problems? Do they have diabetes? Do they have other issues that cause them, other issues? Are they on chronic narcotics? Because patients on chronic narcotics tend to have more of a difficult time with pain management after surgery. And what is the extent of arthritis? So, to give you an idea of how these patient factors influence things, I saw patients today in the office, and I saw two patients, both of whom I did their hip on the same day. One of them came in walking without an assisted device, telling me that he felt almost completely normal. And another was a patient who came in a wheelchair who was using her walker. And the difference between the two patients had nothing to do with how I did the surgery. One of them was young, healthy, and very active beforehand. His arthritis was affecting his life, but it wasn't debilitating him to the point that he was in a wheelchair. And he was able to bounce back quicker to my second patient, who was a little bit older, a little bit heavier, used a walker beforehand because her arthritis was so bad she was barely moving. And so, my point of telling you these two different patients is that patient factors actually have an influence on how you recover. So the second thing with regard to patients is managing expectations. Expectations are tailored to each patient. So to give you an idea, the patient who came in when I saw her initially walking with that walker because of arthritis was severe, I warned her not to expect herself to get rid of her walker like she sees her friends who have had their joint replacement. So that discussion beforehand is important so a patient can know how they are recovering compared to what was expected. Establishing a support system, a plan for postoperative recovery. If you can get family to help you, if you can get rides to therapy for knees, for example, doing things to prepare yourself so you have that support network for the recovery. Um, their level of pain before surgery and their early functional goals. The length of stay in the hospital, that's one of the things as mentioned before that patients define as the recovery. Whether they go home after surgery or not. So most of our patients are going home. I do believe that that's part of a rapid recovery. And some patients coming in, expressing a want to go to rehab for various reasons and misconceptions about the recovery. So a patient will tell me, gosh, I want a recovery as fast as possible and I want to do it in a rehab, which are almost like competing statements. Um, you know, how quickly are they going to reach their functional milestones, getting rid of their assisted devices, getting back to swinging a medium-sized bucket at the golf course, individualizing patient expectations. And then we often share videos, pamphlets, and other educational tools because there are studies to show that a more informed the patient is going into surgery with expectations that are correct, the less fearful they are, and the more they're able to respond appropriately and rapidly after surgery in terms of the recovery. One topic that's often asked, especially for patients who are going to undergo knee replacement surgery, is preoperative physical therapy, what people call is prehab. That's often advertised and talked about. And muscle atrophy and general deconditioning due to pain, stiffness, and disuse of a hip or a knee, common sense would say, gosh, maybe if I improve those things, that will increase my chance of having a good recovery after surgery, improve their strength, their range of motion, and general conditioning. And, all of these things can be helpful. There are a few caveats to preoperative therapy. The first is a patient may go to a therapist and both of them have good intention of getting stronger and mobilizing the joint. The problem is because the knee or hip is arthritic, it can actually end up making that joint hurt even more than it did before they started the therapy. And the more pain that a patient has going into surgery, the more difficult it is to manage afterwards. The other thing from a practical standpoint is many insurance companies nowadays have a limit on how many total therapy sessions you can do after surgery. And specifically for knee replacements, where therapy in my mind is important in terms of formal therapy, you don't want to run out of those allowable visits beforehand by doing it. So I am not a huge proponent of preoperative physical therapy for those reasons. And so that covers that topic. Next are surgical factors. First of it all, the way we do anesthesia is important because if a patient has surgery and the first thing that they feel when they wake up is throat pain from a general anesthesia, a lot of pain because their general anesthesia is now undone and they're having a lot of pain and they haven't had time to take pain medicines, and nausea and vomiting related to a general anesthesia, they're obviously starting off on the wrong foot. So what we typically do in the vast majority of a patients, with a few exceptions, is what's called neuraxial anesthesia or a spinal anesthesia. That's a lot like a pregnant woman getting an epidural catheter for a delivery, but a catheter is not left with the spinal. Instead, the medicine is injected, and that provides numbing to the legs for a period of somewhere between 1.5 and 3 hours so that we can do the surgery. And at the same time, the patient gets medicine to sedate them, much like the medicines that are given for a patient who's undergoing a colonoscopy. So you're not awake or aware of what's going on, but you are breathing on your own. This approach minimizes the side effects with general anesthesia, minimizes the risk of blood clots, and most importantly, when a patient wakes up from anesthesia, when the sedation medicine wears off, their first experience isn't severe pain in their joint because their anesthesia from a spinal standpoint is still working. And as that slowly wears off and a patient feels pain, the nursing team can give medications to slowly build up the pain medicine in their body so that they have a nice smooth transition from surgery to adequate pain control. The next surgical factor, how about the length of the incision? Many patients equate the length of the incision with the speed of the recovery. Of course, the length of the incision can impact cosmetics. The problem is if an incision is attempted to be kept smaller than what's appropriate, it limits the surgeon's ability to see what they're doing. And it also can lead to a smaller wound, but a more poorly appearing wound because it was stretched during surgery. Does it actually decrease recovery time? There was actually an interesting study done many years ago at the Rothman Institute where patients were randomized into a bigger incision and a smaller incision. And these incisions were covered so the patient was not biased in terms of knowing what kind of an incision they got. And in doing this study, it was found that the incision length actually had no impact in the recovery time. So while the length of the incision can affect cosmetics, there's other things that we can do to improve cosmetics. Certainly, you don't want the surgeon being compromised in terms of their ability to see what they're doing and their ability to put the components in good position so that they have good longevity. The way that we do the surgery, that's the next topic in terms of, what influences recovery. And, this is probably the most heavily advertised topic from a patient standpoint. There's, groups and hospitals and surgeons who say, quote unquote, we don't cut the tendon in a knee replacement. From a hip standpoint, the anterior approach to the hip has been heavily advertised, and it's really seen as a newer approach, but it's actually an approach that's been done for a long, long time. And the thinking behind the anterior approach is, well, if you go between muscles rather than between fibers of the muscles, your recovery will be quicker. And the not cutting the tendon with the knee, which here's what we call the quad sparing or the quadricep tendon sparing knee, you go between muscles of the fiber instead of between fibers of the tendon. And the truth is, when you look at well-designed randomized studies, in other words, good quality studies on the effect on the surgical approach on recovery, the truth is, certainly by 6 weeks, it does not make a difference. And in the early point, say 2 or 3 weeks after surgery, there's contradicting studies. Some show that there might be a small difference, and some show that there's no difference. So, does the type of deep exposure influence the speed of recovery? It's an area of debate for the very earliest part of recovery, but most studies suggest that it is certainly not anywhere near being one of the most important parts of the recovery. Um, Pain management and how we manage a patient pain is actually a topic that's way more important, and this is critical. And so the way that we approach pain management is what's called preemptive analgesia, meaning we pre-treat the patient's pain by giving them a combination of medicines by mouth before surgery. Intraoperative analgesia, meaning we give cocktails of medicine during surgery, both to help with pain and also to help with the side effects from the anesthesia and the pain medicines. We do local adjuncts, whether it's injecting around the joint at the time of surgery, doing nerve blocks in addition to the spinal. sometimes even leaving catheters in some situations so medicine can continue to be fed around those nerves. And then there's other things that can be added to the spinal in order to help with pain. One of the keys after surgery is avoiding what we used to use, many years ago, which is a pain pump, where a patient has a button in their hand that they push, and it gives them a shot of narcotic medicines through their IV. And while that gives you instantaneous pain relief, it ends up giving you a lot of ups and downs of pain management, which is not great. In addition, you're hooked up to a machine, and that prevents you from getting out of bed. So we tend to stick to oral medicines with pushes of IV medicines as needed, especially for the first few hours after surgery. The next thing we do is we combine multiple classes of medicines after surgery. We use Tylenol, we use anti-inflammatories by mouth and by IV, we use oral narcotics, some surgeons use neuropathic or nerve pain medicines, and then we also give cocktails of medicines to prevent side effects related to anesthesia and all these medicines. Postoperatively, we encourage early mobilization and therapy. We get patients out of bed and walking the day of surgery. We avoid attaching tubes and lines to them as much as possible. We don't use urinary catheters anymore. Again, we try to avoid those PCA pumps, which are very rarely used nowadays. We do immediate physical therapy, including the day of surgery, and we try to get the patients to meet their milestone to be cleared to go home as soon as possible. And this approach has been so successful that, in the modern day, many patients are actually able to achieve these goals the same day and go home the same day. Where the patient goes after surgery, I would say about more than 95% of our patients go home. If a patient is very elderly, live by themselves, and they're not safe to go home, of course, we're not going to send them home. But as part of the preoperative discussion and setting expectations, I try to encourage patients to understand that going home is actually better for you. Patients that go to rehab actually have a higher risk of complications with surgery, and nobody likes to be in a facility. They'd rather be in the comfort of their own home if possible. So to summarize, the multimodal approach to rapid recovery is what's critical. There's preoperative, surgical, and postoperative factors that influence this. The surgical factors, although they're the most heavily advertised, are actually the least important of all these factors. So if you do a few different things in surgery, but take away all of the other stuff around surgery, your recovery is much more difficult. Whereas you can do surgery in many different ways. And, I don't want anybody to think that I'm talking negatively about any of the ways of doing a hip or a knee. There's many different ways of doing hips and knees, and all of them are very successful. The key is to do them with a surgeon who's comfortable with that approach, who's going to minimize the risk of complications. And the truth is, each of the different ways of doing surgery have pluses and minuses. Common questions I get, I get asked about the anterior hip replacement. I discussed that a little earlier. There's pluses and minuses, and with that, it is a very fair way of doing surgery. You want a surgeon who knows how to do it very well, and it's just their way of doing things, and it's no better or no worse than any other way, is the truth. It's just one of the different ways of accomplishing the goals of surgery. Whether or not to cut the tendon during the knee replacement, this is probably the most common question for knees that I get. And the truth is, there are many, many studies that show that whether or not the you go between fibers of the muscle or the fibers of the tendon has absolutely no influence on recovery. I get asked a lot about robotics, and I'm sure there will be questions about this. Robotics is a tool that some surgeons use in order to help accomplish the goals of surgery. What it does not do, it does not make the recovery any quicker. It does not, it does not necessarily change your outcome. Again, there's pluses and minuses to robotics, and that's another question that we can discuss. Same day surgery, again, is something that we're doing nowadays, and some patients are good candidates and are very big proponents of wanting to go home the same day, and those are the patients we typically do same day surgery on. And then there's patients who are not good candidates or are not eager to go home the same day after a big surgery, and those patients we typically do in the hospital, and they're usually home within 24 hours. They just spend one night overnight. And here's a funny cartoon that a patient actually once sent me that I always chuckle about. So that's my presentation. I'm more than happy to answer any questions that anyone has, and we can spend a good deal of time going over those.
There we go. Sorry, I was having problems logging back in. That was great. Very informative. Thank you so much.
Oh, you're welcome.
And we have some questions here in the chat. So I'll get started at the top. Oh, this is probably a simple answer. After a knee replacement, should your leg be propped up while you're sleeping?
Good question. So that's a little bit of a loaded question because there's a few topics to hit there. So there's really two goals of straight propping up your leg after a knee replacement. One is to decrease swelling. After hip and knee replacement surgery, your leg gets very, very swollen after surgery. It is the number one most common call that we get after surgery. My whole leg is swollen. I'm worried about it. And elevating the leg can really cut down on some of that dramatic swelling. And the second thing is after a knee replacement, most patients before their knee replacement with their arthritis have a little bit of a bend to their knee. It doesn't straighten out all the way. And the knee tends to want to go back into that position, even though during surgery we are able to get the knee all the way straight. And so propping the leg up encourages the patient to keep their leg straight to prevent their muscles from pulling it into that bent position, which, after months, if it's not improved, can become permanent. So those are really the two goals of elevating. So we encourage patients to try to elevate it a little bit so it's above the level of the heart where they're lying down, but more importantly, not sleeping with their knee bent all night so that it doesn't end up getting stuck in a bent
Stuck.
position.
Yeah. I see a couple different questions about resuming activity. Um, I saw two specific to swimming, but I guess, just maybe addressing the, swimming
General activity
specifically and then
level.
just return to activity.
Yep. So first of all, swimming. The big concern with swimming, although getting in a pool can be very soothing and relaxing and can help with pain issues. The problem is with a fresh wound, we certainly don't want any of the bacteria in the water getting in, causing an infection. So I personally ask my patients not to submerge their incision in water for 8 weeks after surgery. I admit that's a little bit of a conservative timeline for me. If I see a patient at 4 weeks, it's the middle of the summer, they're healing perfectly, I might let them go back a little sooner. But by no means is it worth risking getting an infection in your wound by going into water a little sooner than expected. With regard to resuming other activities, think common questions that I get is for golfing. And with golfing, typically by somewhere between 4 to 6 weeks, you can go to the driving range to hit a small bucket. Maybe by 6 weeks, you're hitting a medium bucket. Certainly by 10 weeks, you can try to play 9 holes with a cart. And then by 3 months, you're zooming into activities. But the bottom line is with hip and knee replacements, patients are using a walker for a few weeks, using a cane somewhere between 4 to 6 weeks. And then by 6 weeks, that's when they're really starting to resume their activities that are a little more strenuous, like going to the gym and doing upper body strengthening, maybe getting on although getting on a bike, especially for a knee and a hip replacement, can be beneficial. And is one of the things that therapists do, getting on a bike and riding outside, you don't want to risk falling and harming your wound. So getting back to those things so the first 6 weeks is getting your pain in control, getting your knee moving, walking, and getting through the surgical recovery. Between 6 weeks and 3 months, you're kind of starting to get back into the swing of things. And then after 3 months is when you can really start to resume your full activities.
Great. I've seen a couple questions asking about icing. Do you prefer old-fashioned ice, the newer ice machines? What do you
Right.
usually recommend?
So I usually recommend old-fashioned ice. It's interesting. The thing that I don't love about the ice machines is they're not as well regulated. And so, I've heard of patients falling asleep with the ice machine on. Nobody's there to take it off. It stays cold for a long time, and then that can cause frostbite injuries and wound problems. And one of the benefits or one of the things that's annoying about old-fashioned ice in a bag is that one of my patients told me, well, the ice melts and then I have to go get a new ice. And I said, exactly, that's the point, is that you're less likely to get frostbite because of it. Now, many patients do use those successfully. I don't use them routinely. Again, they're not as well regulated, and I'm not a huge fan of those, but many surgeons use them with success. So, it's as long as ice is applied safely, it's okay.
Great. Um, any ideas on how to prevent surgery? So I guess things to do before we get to that point.
So the first thing is, the patients who end up getting surgery the first day that I meet them in the office are the ones who come in saying, my knee or hip has been killing me for 2 years. It's progressively gotten worse until they're to the point that they're barely walking, right? Because nothing's going to help that patient. They just waited a little too long. The earlier you see somebody with your pain and the more treatment you get, the more you can keep the pain at bay. Now, nothing that we do is really going to stop the arthritis from progressing on the x-rays, But in my mind, the earlier that you treat the problem and keep the inflammation at bay, the more successful it is. So if I have a patient with bone on bone arthritis and a crooked leg, they are less likely to have non surgical treatment help. Whereas somebody with early arthritis, there's a better chance of success with things like injections and oral medicines and braces, and those things can keep the pain at bay. In addition, activity modification is important. If you love to run and your knee has bad arthritis and you keep running, you're just going to make your knee get more inflamed. So sometimes it's a matter of changing your activities to things that still allow you to build a sweat and get enjoyment out of that activity without putting too much load on the hip or knee to make it hurt more worse or make the arthritis get worse.
Great. It's a great question about prehab. What should the goal be? Should it be increasing muscle mass or increasing flexibility? Which one is more
Good
important?
question. So the most important thing with prehab is to not make your pain worse. Because if you're pushing past pain to try to get your muscles stronger and try to get your hip or knee more flexible, again, then you go into surgery with more pain and you end up having more pain after surgery. Because the more inflamed the joint is going into surgery, the more it gets irritated by us attacking it doing the surgery. And so the goal of prehab, and I encourage patients to do it on their own, whether it's getting on a bike or doing low impact activities, is to try to gain strength and flexibility without causing severe pain. So that's my guideline, is do as much activity as you want with trying to strengthening and make your hip or knee more flexible without increasing your pain substantially. How do you know that? Well, if you're needing to take more pain medicines, if you're feeling the pain more often, you're having trouble sleeping at night, that probably means you're overdoing it.
Speaking of pain, there's several questions about pain management post-surgery. Questions about can you manage it without narcotics? What can we use besides NSAIDs?
So, we do encourage patients to take NSAIDs after surgery as long as there's not a medical problem that stops from using it. We also ask them to use Tylenol because the combination of the two can work very well. And then we prescribe narcotics just as needed. You don't have to take the narcotics, but they're there for if you need them. The truth is, a knee replacement is a bit more of a difficult recovery than a hip replacement. It's not uncommon for my hip replacement patients to just take a day or two of a light narcotic to help with their immediate pain, and then they're off of it and only on Motrin and Tylenol. With knee replacements, it's a little more. Now, the pain medicines, nobody wants to be on them for a long time. They can also cause side effects. But I think it's important to understand that there's different levels of pain medicine. Some are stronger than others. So we try to find that fine balance of giving you a medication that's effective and keeping your joint in pain and control so that you can actually participate in therapy for knees versus having the side effects and not feeling well because you're on the narcotics.
Okay. How long can you expect a new joint to last?
Good question. So the best literature that we have on that is that if you get your hip or knee replaced when you're over 60, it's unlikely that you'll need a revision. And the reason for that is twofold. First of all, in general nowadays, hip and knee replacements are lasting a long, long time. I don't know that I can give you a specific number. What's predicted for hip replacements is 40 to 50 years. For knee replacements in general, 15 to 20 years. But doing a joint replacement on a very young patient who's really using their joint strenuously versus doing a joint replacement on grandmom who's walking with her walker are obviously two different, levels of use. And so when you're over 60, you tend to become a little more active in terms of high level activities. And the average life expectancy is 75 to 80. So if you take that number of 15 to 20 years, it makes sense that if you get it done when you're over 60. Now, if you're 55 and you have bad arthritis, that doesn't mean you should necessarily wait until you're 60. That the 60 isn't a magic number. It's more of a general guideline of predicting whether or not you might need a revision. The truth is, a revision is not much more difficult than the first time around. So, in my mind, I do not hesitate to offer a younger patient surgery, if they need it, because the revision isn't the end of the world, is the truth.
Okay. Speaking of revisions, can an anterior hip revision be done after an initial posterior replacement?
So that's a good question. So any revision can be done through any approach as long as it's not shortly after the initial procedure. So the short answer to that question is yes, with the one caveat is if you have an anterior approach and have a complication and go to another surgeon to manage that complication and then you get a separate approach, now you're damaging tissues from both sides of the joint and that can lead to the hip popping out of the socket. So, I do revisions myself, and I always do it the same way, and it doesn't matter what initial approach they had. But if it's soon after surgery, you're best going through the same fresh wound that was initially gone through, if that makes sense.
Makes a lot of sense. Couple questions about stairs after surgery, people living on the second floor, having steps, a lot of steps walking into their house. So what do you advise
So
when
you
that's the
are able
case?
to go being able to maneuver stairs is one of the criteria to going home because you can't, the therapists in the hospital assume that you have stairs to go home with, although they ask you what your accommodations are at home. We really require that patients do stairs before they go home, and that is a requirement for patients also going home the same day that I do in the surgical center. So those patients, we do their surgery, say at 9 in the morning. We're done their surgery at 10. They go to the postoperative care unit. By 11, their spinal's worn off, and a few hours later, they're doing stairs. It's pretty amazing, but it's what we're doing.
And on that note, how soon after surgery would you expect the patient to start physical therapy?
So it depends, is the short answer. So the spinal has to be worn off, and the patient's pain needs to be in control. Age, and their level of activity and functionality before surgery plays a role. So it can be anywhere from in a surgical center where they're actually doing stairs a few hours after we're done the procedure, to an elderly patient who is very debilitated in the hospital who doesn't get much out of bed the first day. So there's a range, but what's possible is doing stairs within a few hours of surgery.
And I know there's some differing opinions on this. Thoughts on postoperative physical therapy for hip replacements?
So that's a good question. So for knee replacements, it's a little more controversial. Many of my partners don't have their patients do formal physical therapy after a knee replacement, and they do just fine. I personally do have my own patients or encourage them to do physical therapy as an outpatient, not because I think it's the end all be all or it's the make or break of the recovery, but it's almost like somebody who doesn't like to exercise, who gets a personal trainer to get motivated and to get some direction as to how to exercise. I think having a physical therapist working with you closely after a knee replacement is important because stiffness can happen with a knee replacement or lack of range of motion, which does not tend to happen with hip replacements. There are actually downsides to formal physical therapy. Sometimes they cause more pain rather than decreasing pain. Sometimes they give, messages and raise concerns that really aren't to be of concerned about, like gosh, there's swelling in the leg or the incision looks a little discolored and they, sometimes cause more problems than they solve. But the important part is physical therapy beneficial? And for knee replacements, there are studies to show that it could go either way. With hip replacements, there have now been several studies to show clear as day that physical therapy does not influence recovery time, your final outcome, or any other real factors. So just about nobody at the Rothman Institute has their hip replacement patients doing formal physical therapy for that reason. I think it actually has more downsides, is really not as many upsides.
Great. I see a couple people asking about expected range of motion, a specific asking heel to buttocks, I guess, is what's the
Right.
expectation
So the
after knee
key is
replacement?
every patient is different. Some patients come in to see me 4 weeks after surgery with a tremendous range of motion, and others come in with a good deal of stiffness. The goal should be the first week after surgery to get the knee moving and bending within the limits of your pain as much as possible. And then I usually have my patients start formal therapy a week after surgery because I don't want them to be in a lot of pain that first week or more pain than they need to be in. So once formal therapy starts, then the therapist helps you do it. And on the one side of things, some patients get their range of motion back immediately. On the other side of things, some people develop scar tissue in their knee. It's more difficult to get their range of motion. So what's important to note is that every patient is different. My goal is to have a patient at least with 90 degrees bent in their knee by the time I see them in the office, not because that's all I want them to get, but because in my mind, that's a good predictor of their final range of motion. If they're beyond 90 degrees, that's about what's needed to get your legs around the pedal of a bike. And once you can do that, you can really get the knee moving. Whereas the patients who come in to see me with less than 90 degrees, there's some interventions we can do to improve that situation, but that's somebody I'll watch a little more closely. In terms of heel to buttock, there are some inherent restrictions with range of motion with a knee replacement. So if you're touching your heel to the buttock before surgery, you probably don't need a knee replacement because most patients with arthritis that's bad enough to need a knee
Can't
replacement
do that.
have a degree of stiffness that they can't do that. And so that's usually not the goal of most patients to touch their heel to the buttock. And if it is, you're probably not ready for a knee replacement.
I've seen a couple questions asking about blood thinners, postoperative blood thinners.
Good question. So the point of blood thinners after surgery is to minimize the risk of blood clots. And there's two general classes. There's the heavier blood thinners and the lighter blood thinners. The lighter blood thinner is aspirin, which is what we most often use. The heavier blood thinners come in different flavors. There's Coumadin, there's Lovenox, there's Eliquis, there's Xarelto. Pills or injections. Some of them need blood work, like Coumadin for monitoring, and others don't. Um, this has been extensively studied. It's probably the single most studied thing in joint replacements. And what's been learned about is, everything is about a balance between preventing blood clots, but also preventing bleeding complications. And it's been clearly shown that a patient who has a low risk of blood clots, aspirin is an effective way to manage and minimize the risk of blood clots while really minimizing the risk of bleeding. Whereas patients at a higher risk of blood clots, like those with active cancer, those with a history of blood clots, or those with a clotting disorder, are best served with a little bit of a heavier blood thinner for 4 or 5 weeks after surgery. No matter what medication we give you, there is a small risk of blood clots after surgery. And no matter what blood thinner we give you, there's a risk of bleeding. It's really a matter of finding a balance between the two.
Great. Couple questions about bilateral in terms of hips as well as knee. Do you recommend, not recommend? How long in
So
between if you don't recommend?
Yep. So it was very popular to do bilateral hip and knee replacements years ago. And I would say that the popularity of those procedures have gone down over time, although you still can find surgeons who do it, generally in a younger, healthier patient. I personally don't recommend bilateral knee replacements. And again, this is an area of controversy and personal preference. I'm a little bit of a more conservative guy when it comes to, joint replacements. Not to say that it's crazy to do bilateral hip or knee replacements, but I would say it's overall become less popular. The disadvantage is number one, in most cases, you end up having two painful joints, and it's hard to recover from that. There's some evidence that it can actually increase your risk of blood clots. And my biggest thing is that if you get a complication that actually ends up affecting both joints, like an infection, that's a really, really bad problem. Not that getting one infection is not a bad problem, but getting them in both joints is a really bad problem. So I am not a fan of doing both in the same setting. That said, there are patients with severe arthritis in two joints that want to get both fixed as quickly as possible. So what I typically recommend is staging them, and it can be the second joint can be done as soon as 8 weeks later. When you look at our studies on when is the point in time when your risk is back to normal, it's right about 8 weeks.
What about driving post-surgery for hip and knee?
So that's an individual thing. Everybody's a little different. When you look at our studies, what needs to be done is two things. Number one, you can't be on narcotics. Each narcotic that you take is like drinking an alcoholic beverage. So you obviously can't do that and drive. And the second thing is your reaction time has to come back good enough that you can drive safely. And obviously, we can't watch every patient drive. We're not driving instructors, so we can't tell you when you're safe to drive, but you have to be off of narcotics during the day and you have to feel safe and be able to drive safely. So we usually recommend to test drive around the block and then, drive locally at first and then advance from there. In terms of the average time to driving, for a left hip or knee replacement, it's typically 3 weeks. And for a right hip or knee replacement, it's 4 weeks because that's your driving foot.
Okay. Um, how long after another surgery? Somebody mentioned that they'd had a spine surgery and now have a problem with their knees. How long would you recommend in between one major surgery and
I
a knee
usually go by
replacement?
that 8 week point of time.
8 weeks. Okay. Sleep positions. I've seen a bunch of questions about sleep positions post-surgery.
The only thing we ask you not to do is to lie on the wound. So for a hip, you don't want to lie on that side. You can lie on the non-surgical side. Usually patients put a pillow between their legs. You can sleep in a recliner or you can sleep on the bed, on your stomach, on your back, or on the non-surgical side. For a knee, we just don't want you sleeping on your stomach because we don't want the incision, being buried in the sheets all night. Sleep disturbance is the most common symptom afterwards. It lasts about 3 months. It's annoying because you keep waking up at night. We usually encourage for the patients to take medications before bed to help with their pain, but it's one of those things that you sort of just have to put up with for a few months after your joint replacement.
Um, Question about, is a vagus knee corrected with knee replacement?
I'm assuming they meant valgus knee. So a
Oh,
valgus knee is a knee with a skier's deformity where their knees are like knock-kneed. And so usually that is caused by arthritis on the outer part of the knee. So the outer part of the knee collapses and that makes the knees point inward. And so, yes, a knee replacement is to treat a varus or a valgus knee. And one of the goals of surgery is to straighten the leg out so it's not a crooked leg anymore.
Any recommendations for over-the-counter supplements to help with knee arthritis?
So there, in terms of it depends on what you mean by helping arthritis. If by helping it you mean, getting growing the cartilage back or undoing the damage or preventing it from getting worse, there really is no medication at this point that does that. In terms of medications that help decrease the inflammation, you're looking at anti-inflammatories like Motrin, Advil, and Tylenol. If you're an all-natural type of person, fish oils act very similar to anti-inflammatories. Some patients where it's severe and surgery is a bit of a wait for medical reasons, we sometimes use short courses of narcotics to help with the pain. There's all kinds of topical agents that are tried, including, CBD creams and ointments and the topical NSAIDs. So there's all kinds of different things out there. And then there's obviously the injectables, and they help as well, whether it's cortisone, which is almost like hydrous Motrin right into the knee, or if it's one of the gel shots, which, unfortunately does not actually restore cartilage, but does in some cases decrease inflammation.
Stem cell therapy, thoughts?
So stem cell therapy is experimental at this point. There are studies being done on it, but the important thing of it being experimental is that insurance doesn't pay for it. So you end up paying a lot out of pocket, and it's not proven. There's really no study that shows that it acts any better or much better than cortisone or gel shots. Certainly if you have severe arthritis, it's a waste of time and money to go ahead and do those things. If you have early arthritis, you have failed all other treatment options and you're not quite ready for a joint replacement because your x-rays don't look bad, then maybe in that situation it's worth trying. But anything that's not covered by insurance is not proven with science. And so, that's something you have to be careful with.
Um, are there any permanent restrictions? I know this is probably based on each patient, but in terms of like running, jumping, do you ever say, don't ever jump again, don't ever run
So
again?
for knee replacements, I ask my patients to stick with low impact activities, swimming, biking, cycling, cycling, hiking, those kinds of things. Now, if somebody's chasing you, you can run, but most knee replacement patients report that they prefer not running because a knee replacement clicks, it makes noise that's, inherently doesn't have the same mechanics of your own knee. Um, Squatting isn't necessarily a good idea. Lifting really heavy weights with your legs. You can still lift weights, but I certainly wouldn't try to become a bodybuilder from a leg standpoint after a knee replacement. They're the big things with the knee, and again, some people don't listen and they go ahead and run and jump. But it certainly should not be an expectation or a mean goal beforehand. With regards to the hip replacements, it's a little bit different. Many of my hip replacement patients run marathons, do triathlons, so you can really be fully active. The only thing I ask my hip replacement patients not to do is to try to become hyperflexible with their hip because a hip replacement can dislocate. It's inherently more unstable than your own hip or knee. I'm sorry, than your own hip. It's not easy to dislocate a hip, but some people trying to do advanced yoga maneuvers where they're trying to put their heel behind their head, that makes me nervous. So, I ask patients not to try to stretch their hip into an abnormal position.
Is there a kind of maximum age? I know it's probably patient dependent, but if somebody's say 87, in good health, would you say go
Yeah.
ahead and do
So
it?
age is a number. In general, I start to get nervous when a patient's over 80. But again, age is a number. I've operated on patients in their 60s who are way more unhealthy and risky than somebody in their mid 80s. And so you have to take the whole picture into play, what their functional status is. I would say overall, maybe I get a little more nervous, especially from a medical standpoint. Now, we do give all of our patients a thorough medical screening, seeing a medical doctor, getting blood work done, and making sure they're as good as they can be. But I get a little nervous when a patient's over 80. That said, I've done plenty patients in their 80s with good success, and even some in their early 90s. So it certainly can be done. It's just obviously the older we get, the surgery becomes a little more risky, but still safe.
There was a request for you to close the presentation. They want to see your face
Oh,
bigger.
sure. Oh, I didn't realize my face wasn't showing. I'm sorry.
Oh, it's there, but it's like a little box.
Oh, okay. How do I make the
Maybe stop sharing your screen.
Oh, okay. Is it still sharing or no?
It's still sharing. If you go, I think at the top it'll say like share my screen and stop sharing.
Oh, I see. Stop sharing. There we go. There we go. Is
There you
that better?
go. There we go. Um, I have lots of questions asking how long does the actual surgery take for the knee and the hip?
Each take about an hour.
Best. Um, let's see. How complicated is a reconstruction to fix a reconstruction surgery, I
So
guess? How
that
long
that's
does
a
that?
that's a loaded question. It's variable. There are some reconstructions that are very straightforward and take even less time than a first-time hip or knee replacement, and there's ones that take 3 to 5 times longer. So it depends on the situation. It depends on the level of bone loss. It depends on how complicated the situation is before. I've done some very simple revisions that are straightforward and life-changing for a patient, and I've done ones where a patient's on their 10th surgery and they're often much more difficult. So there's a lot of factors that go into that, but the short answer is there's a lot of variability with that question.
Um, how long after an injection would you want somebody to wait before you would consider them for
Three months. So there's some evidence that up to a year after an injection, your risk can increase. Certainly by 3 months, that's the strongest evidence. So my restriction is 3 months, and I think that's a good number to go by because we don't really see many complications in those that wait at least 3 months. But that's the Rothman protocol is to do no more than 3 months, not within 3 months of an injection.
if someone has an uncomplicated hip replacement and a fairly sedentary job, how long would you estimate until they can go back to work?
So it's really the limitation is when you can drive to get to work. I've had patients work from home sooner, but getting to work is usually 4 or 5 weeks to be able to drive yourself. So, before then, possibly if you have somebody drive you going for a half day just to get your feet wet again, but for a simple job, I usually say 4 to 5 weeks.
I see a couple questions asking about PRP.
Yeah, so that's very similar to the stem cells. It's a little different in terms of what it's made of, but my feeling on PRP is very similar to that of stem cells. It is still in the investigatory or experimental stage, and studies are being done on it. Certainly, there aren't strong studies to show that somebody with severe arthritis that it's the end all be all and it makes a big difference. So similar to the stem cells, it's not something that insurance covers. So if you are being told that you are a candidate for a hip or knee replacement, I wouldn't bother with those. If you're somebody with very, very early arthritis who is not a candidate because your x-rays don't look bad enough yet and you've tried everything else, then maybe it's worth a try for that reason. But
I've seen a bunch of people asking about kneeling after a knee replacement. How long until you can kneel? Are you able to kneel?
you're allowed to kneel, but 50% of patients after a knee replacement report that they prefer not kneeling just because of scar tenderness. So you're not going to hurt the implant by kneeling or damage anything, but because the scar is in the front of the knee, which is the safest place to do a knee replacement in the front, because there's less nerves and arteries and other important structures in the way. Because the scar is there, some patients report that they prefer not kneeling. Now, many patients who are gardeners and such will use pads or will start kneeling on their other knee, so they find ways around it. But my biggest concern is somebody who needs a knee replacement and has a job that requires that they kneel. And so I have a long discussion with that patient to make sure that they understand that statistically, 50% of knee replacement patients report that they prefer not kneeling after surgery.
What about high heels?
High heels are fine once you're done the healing. Most patients are able to use high heels.
Are there any issues or concerns with patients that have osteoporosis?
Good question. So, yes, anytime a patient has osteoporosis, that can be a concern. In my mind, there's two categories of osteoporosis, one that's seen on a DEXA scan and one that you can actually see on the x-rays. If you can see the osteoporosis that it's bad enough that it's on the x-rays, then, that's of concern to me, and we may have special implants or change the way that we do the surgery in order to minimize those risks. If it's somebody that has osteoporosis on the DEXA scan, but their x-rays don't really show it, then I don't worry about it too much.
Okay. Just do a couple more. I've seen a bunch asking about the materials used for hip replacements, knee replacements, and what to do if you have a nickel allergy or if you have an allergy after the surgery is done.
Right. So hip replacements are titanium metal, polyethylene plastic, and most of us are using a ceramic ball because if you put a metal ball on a metal stem, sorry, I don't know why my picture keeps doing that, you can get a metal reaction that can cause a problem. The reason that you're able to use all titanium for a hip replacement is that you have ceramic rubbing on plastic, so you don't actually have any metal rubbing on a surface. The actual joint surface is metal ceramic on plastic. In a knee replacement, you have metal on plastic, and so that metal that is rubs on the plastic has to be smooth polished. And titanium is a metal that is a little softer and it can't be smooth polished as effectively. And so if you do smooth polish it, it can develop rough edges that can affect the longevity of the implant. So from a metal standpoint, we use cobalt chrome for a knee replacement. Now, what if you're nickel allergic? Well, if you have the most common nickel allergy reporting is because a patient comes in saying that they respond to jewelry, for example, and that means that their skin is alert. They show a skin reaction to a metal. There's really no evidence that that has an impact on you rejecting a joint or being allergic to the joint. But if a patient volunteers to me that they've had issues with allergy to nickel, I don't use a nickel implant. There are alternatives. One is to actually use titanium in the femur component. The issue with that is that we then worry about longevity because of smooth polishing. The other option is to use a different type of metal called one of the implant companies uses a special material called oxinium, which is it's not quite a ceramic, but it's like a ceramic, so it doesn't have as much nickel in it, and it's what I typically use for a patient who reports a nickel allergy.
Great. There's a question about extended swelling. If you have swelling a year, 2 years after surgery, is it cause for concern, and why would it happen? Is there anything we can do for it?
So, outside of a certain period of time after surgery, say 4 or 5 months, you would expect that any swelling from surgery would be gone. If there is residual swelling, one thing you do worry about is blood clots. Now, at that point, it would be a chronic situation or maybe one that pre-existed. So, ruling out a blood clot in somebody with chronic swelling after a joint replacement is, a good idea. The next thing is some patients' veins or lymphatic system doesn't work well to pull their fluid back, and when you do the surgery, the leg gets swollen, and then your body doesn't want to pull that fluid back to resorb it. And so, in that case, you may have an issue with your veins, and you might want to see a vein specialist to say, hey, do I have an issue with the function of my veins? And then support stockings, and sometimes procedures can help with that. But most patients who develop residual swelling long after their hip or knee replacement had some pre-existing swelling beforehand. So they knew that that issue was there. But occasionally I will get a patient who said, gosh, my leg was never swollen before, and now it's a year after surgery and I'm still retaining fluid. What's going on? So we usually have them see a vein specialist to see if that's what's going on.
Okay. I'll just say we still have so many open questions. We'll do maybe 3 or 4 more questions. I think we could stay here all night answering these. Some things I've seen repeatedly. What are your BMI requirements,
Good question. So the
if you have
concern
any?
with a BMI is there are certain ranges of BMI. But for those who don't know, BMI, body mass index, is a number that takes into the equation your height and your weight. And so it's one of the very straightforward assessments of a body type. And obviously, it has limitations. Somebody can be very muscular in great health and have a high BMI, and somebody can actually be underweight and be unhealthy for that reason and have a low BMI. But it is a good kind of quick and dirty way to assess a patient's overall body type or body status. And the Rothman Institute used to have a rule that if the body mass index is over 40, we don't operate until it's lowered. And the reason is that there is some evidence that if your body mass index is over 40, then your chance of a complication is higher. And like I said, more important than rapid recovery is to get through the procedure without a complication, because complications can be devastating. Then some evidence came out that if you take that patient with a body mass index of 43, let's say, and get them down to a body mass index of 39, their risk doesn't actually decrease all that much, yet they suffered for that longer time with arthritis. So maybe 5 or so years ago, Rothman changed their protocol so that if the body mass index is between 40 and 50, we certainly have the patients try or make sure they've tried to lose weight. We also make sure they fully understand the implications of complications when they happen. And we also check a set of nutrition labs to make sure their nutrition is okay, because believe it or not, if you're overweight, sometimes your nutrition can be poor. And the other factor that I think is important is a patient can have a very high BMI, but it's all in their belly and their knee is not a big knee, and their risk is probably not as high as somebody who carries a lot of their weight in their legs. So each patient is an individual. We work with every single patient, even if they have a high BMI, and come up with a game plan of how we're going to get them to lose weight. I've had patients lose a ton of weight, have extra skin that's gonna get in the way of the incision, and we send them to a plastic surgeon to get skin removal surgery and then do their hip replacement, and they're as happy as could be because they got through the surgery safely. So we individualize each patient and come up with a plan. It's not, oh, you're too heavy, we can't operate on you. It's, hey, these are the risks. Here's what we're going to do to decrease your risk so we can do the surgery successfully.
Great. MRIs after joint replacement.
Good question. So the short answer is yes, you can get an MRI after a joint replacement, even an MRI of the joint that's affected. There are some times that we get an MRI of the joint that's affected to look for certain pathology. What's interesting is I recently had a radiologist to reach out and deny one of my patients an MRI of another body part because they have a hip replacement of a specific design and of a specific company, and they told me that they've had a few of them have pain during the MRI. So you can actually get a little bit of vibration of the metal that can cause pain in rare cases of an MRI. But the short answer to your question is you can get an MRI after a hip or knee replacement, and in the vast majority of the case, the patient wouldn't even know that they had a joint replacement in getting that MRI.
Wonderful. And we'll take the last question. How many total knee replacements do you do per week?
Oh, per week. Well, I think in year instead of per
Or you
week.
can think in years.
Yeah, so I've been in practice for about 16 years. At first I wasn't doing as many as I've built the practice of patients, it's increased. I do about 850 hip and knee replacements per year, which amounts to just about a little over 60 per month. So per week, that's probably between 10 and 15. And so, that's the number. I try to, I don't operate till midnight. I try to be done, by 3 o'clock whenever possible, so that patients aren't finishing late at night when the good anesthesia team's not there and the good staff are there. We also start very early, so because they're 1 an hour, if it's we can get through the day, a normal day, and do anywhere between 6 to 8 joint replacements per day.
Wonderful. I think that will be it for now. Like I said, we still have over 200 questions open. A lot of them are similar, but
Appreciate it.
it just goes to show there's a lot of information that people want to know and why we had lots of people log in with us tonight. So I just wanted to say thank you so much for
Sure.
offering your time and your knowledge. My information is in the chat, as I said earlier. If you have any specific questions, I can absolutely help you get a patient in with or get you in with Dr. Derimengian. And I think that's it. Any final words?
No, it looks like we broke the record for most participants for a lecture, huh?
I really think so. I've never seen this many.
But
So,
I'm
well,
not at
thank
all
you so
competitive,
much.
though.
And thank you guys for thinking of Rothman. We are here to help with any of your orthopedic needs and have a great night.
Thank you. Thanks for coming on.
Thank you.